all, I am Dr. Shweta Santhalia, the course director and mentor at aimmrcog. And today we are going to discuss cervical cancer in pregnancy, the recent talk of 2022. As cervical cancer and all the cancers are always important, as well as the survival, the treatment, all that are favorite questions of exam in the part 2. And this is a recent talk. So definitely earlier also we were having trachelectomy talk, and earlier also we were having many talks on cancer. So this recent talk definitely makes cervical cancer in pregnancy very important for MRCOG part 2 exam coming. So that's why I thought that we will discuss this today to make it simpler and easier for you. So before starting the discussion, I'm very delighted to announce that AIM-MRCOG is live now. So you can visit our website, and once you visit our website, you can book a free session for part 2 on consent, which is the most challenging topic for most of you. So it will help you in understanding the consent well, and definitely the exam questions on consent are little challenging and confusing. So it will give you clarity. So if you want to book the free session, you can click on this link and you will go to the Google form, fill it, and you will be able to book your session on consent on 15th of May. If you see in the website, you will have different courses. If you need a personalized plan, like you feel one module is difficult or two module is difficult only for you, you can choose the personalized plan here. There are free resources for your help. There are testimonial where it has been the nice words of all our students are there, which you can go through, which will help you in understanding how uh, the students who are already enrolled in AIM-MRCOG, what they say about the course and how satisfied they are. So if you have not booked it, book your free session through this Google form. Eid offer for part 2 exam. If you have many congratulations if you have already booked your exam for the July, and if you are planning for September or January, we have offer for the huge offer is going on for all the courses. Last 3 days to avail these offer. If you are interested, you can avail these offers. Now, let's start with the cervical cancer in pregnancy. If you see cervical cancer, why it is important? First of all, we have to understand why it is important, because this is the commonest gynecological malignancy in pregnancy. So if you see, because it is commonest in pregnancy, that's why they ask you cervical cancer in pregnancy. So what is the incidence? If you see the incidence, 0.1 to 12 per 10,000 pregnancy. So it's not very common thing. If you see, it is in 10,000.1 to 12. It's not very common, but this is the commonest of all the gynecological malignancy. So this is important. So cervical cancer in pregnancy, you should know the management and how it behaves and how to diagnose, when to investigate, how to investigate. All these things you should be having clarity in your mind so that you can do the questions correct. Why this is very challenging to diagnose in pregnancy? Because in pregnancy there will be more chances of spurious diagnosis, because pregnancy symptom like pain, bone pain or urinary problem, bowel problem, all that problems are already there in pregnancy. So this cancer symptoms will always be like vaginal discharge, bleeding sometime, urinary bowel problem or pain. So all the symptoms can be same like pregnancy, so there will be difficulty in diagnosing this. That's why there will be delay in diagnosis in pregnancy. Now, staging is essential. Obviously, if you do a proper staging, then only you can do a proper management. So, staging is very crucial, that you stage the cervical cancer properly. And then the treatment in pregnancy is also complex, because you have to deal with the mother as well as you have to look for if you can save the baby. So baby life is also important. That's why it's more challenging to treat the cervical cancer in pregnancy, and you have to consider the baby also, depending upon the age of gestation. So that aspect you have to take care. It's always with multidisciplinary team whenever there is any complications or any complicated situation, and in oncology anyways, it will always be multidisciplinary team. So it will involve the neonatologist, the psychologist, the physiotherapist, the investigation specialist, everything. Means it will have, other than gynecologist and the oncologist, all other speciality which will help you in making the right plan for the mother and the baby. Now, if you see overall nowadays, because of the vaccination, HPV vaccination, now they say in the recently they are saying that it is recommended to give to boys as well as girls both at the school age of 12 to 13. So if you give the vaccination to the girls as well as the boys at that age, it will decrease the incidence of cervical cancer in the early age. So earlier, the peak age was 25 to 29, and now they're saying it is shifting to 55 to 59. So it can shift because of vaccination, is what they are trying to tell you. So that's an important aspect. Now, relative risk of cervical cancer, if you see, it is lower during pregnancy compared to non-pregnant women. So it's a good news that overall the relative risk is lower in pregnancy. But if you see the incidence, it is zero point 0.1 to 12, and it is the commonest one, so you are worried. Then they say that there is no enough data to say that how the pregnancy is going to affect the cancer. Will it be more severe, less severe? But they say that the prognosis could be poor in small studies. So that's a concern. That's why you want to diagnose it properly and treat it properly to give her the best care. Now, cancer prevalence, the most common SBA question in exam. What is the most common cancer in women? If they ask you most common cancer, it is always lung cancer. If they ask you most common gynec cancer in UK, it is endometrial cancer. If they ask you most common gynec cancer worldwide, it will be cervical cancer. If they ask you most common gynec cancer in pregnancy, it will be cervical cancer. If they ask you most common gynec cancer leading to death, it will be ovarian cancer. So these are the most common. Don't forget this because these are the simplest SBA to do correct in exam. Now, diagnosis. How you will diagnose cervical cancer in pregnancy? Very important. How you will diagnose? So for diagnosis, there are two things. One's clinical thing, because the cervical cancer is a clinical diagnosis. So one, it's clinical thing, the symptom, the examination finding and all that. And the other aspect will be investigation. So what will be the symptom? If it is very early stage, it could be simply asymptomatic and nothing else other than abnormal smear. So it could be simply asymptomatic, or sometimes there could be symptom, as I told you earlier, that it will mimic to the pregnancy symptom. So it will be difficult to diagnose. Then you will do the examination and referral. So definitely any women, if they are presenting with bleeding in pregnancy, you will do the per speculum examination to visualize the cervix, because it could be anything. It could be benign ectropion, it could be placenta, it could be abortion, it could be cervical cancer, polyp, anything can be there. So whenever bleeding in pregnancy, you always have to visualize the cervix to rule out the cervical cancer in pregnancy. And if you see any cervical abnormality, like you are suspecting that there could be a cancer, then you have to refer her in an urgent way. So 2 week rule. So 2 week referral pathway is what you will follow, and you will refer her to the colposcopist or the gynecologist. So this is very important. The 2 week rule of referral is very important. And as I told you, that symptom could be confusing. Now, the other important aspect asked in exam is when you can defer the smear, when you have to do it, and when can you do the colposcopy. So this is very important exam question, that when you will defer the sampling till 3 month postpartum. So if you see cervical screening in pregnancy, pregnancy itself is not a contraindication for a smear test, but as I told you, there will be more spurious result. Why spurious result? Because there will be more cervical mucus, more hyperemia, more columnar evasion, columnar epithelial evasion. So all in all, there will be more chances of wrong interpretation. That's why you want to avoid the routine things. You want to avoid anything you can avoid, because you don't want to unnecessarily overdiagnose and overtreat. So that's why it's not a contraindication. But if it is safe to delay, you want to delay it, because ultimately pregnancy is only 9 months. So if you can delay it safely for 9 months, you want to delay it. So in what are the situation where you can delay it? If it is a routine recall, you can delay it because it's a routine recall. So there is no, you're not suspecting anything. It's just a routine screening. So better to delay it to avoid false diagnosis. Or if it is a test of cure smear test, or if it is a CIN1 in the colposcopy in the NHS CSP guideline, if you see CIN1, you can delay. Test of cure for CIN2 and 3, if the margin was clear, you can delay. So that means if you have treated well, the margins are clear, you have treated well, you can delay, no harm. Or CIN1, anyways, you CIN1, you are going to follow it yearly. So if you are following it yearly, 9-month pregnancy, if you don't do anything, it's okay, acceptable. So these are the three conditions: routine recall, test of cure for CIN 2 and 3, where the margin were clear, or CIN 1, where you will defer the testing until 3 months after delivery. This is very important, when you will delay. And the other aspect is when you will not delay. So you will not delay if it is CGIN. If you have treated for CGIN, CIN 2 and 3 with involved or uncertain margin. So if the margin is not clear or uncertain, you cannot delay because there is a risk. She could be positive margin, she could be invasive disease. If the margin is not clear, means it could be invasive disease also, and CGIN is always more dangerous. So CGIN or CIN 2 or 3 with involved on a certain margin, you are not going to delay it after the delivery. So what you will do? You will do it. You will do it then and there. So you will do the smear and accordingly you will decide about the colposcopy. So what is your idea about, can we do colposcopy in pregnancy? Anyone? Yes. Okay, good. Good, my dear. Yes, colposcopy is safe in pregnancy. So colposcopy and excisional biopsy, if needed in pregnancy, you can do because it is safe in pregnancy. And why you are doing it? Because you want to exclude the invasion and you want to defer the biopsy until the woman has delivered. Why you want to defer the biopsy? Because if you want to rule out the invasion, you have to do the biopsy. In that case, it will be incisional biopsy, and incisional biopsy can be a risk for pregnancy. There could be preterm labor, there could be more hemorrhage. They say 1 in 4, 25% there will be hemorrhage, so it should be done in the OT setup. So excisional biopsy is something challenging in pregnancy, and to rule out invasion, you cannot do punch biopsy because punch biopsy will not be more informative for invasion. So you have to do the excisional biopsy. That's why you want to defer the biopsy until the woman has delivered to keep her safe, to avoid the hemorrhage, to avoid the preterm both ways. So if you see the hemorrhage, they have written it is 1 in 4, 25% chance of excessive hemorrhage when you do the biopsy. That's why you want to delay it if possible. But if it is not possible, you will do it because her safety, the women's safety is your main concern. When you will do the colposcopy, if you see the NHS CSP, the guideline of Feb 2020, they have clearly mentioned that you will do the colposcopy in the late first or early second trimester. And if you find that the lesion is high grade, you will repeat it again at the end of second trimester. This is very important because colposcopy is not also, colposcopy has also the limitation due to pregnancy. One normal colposcopy, if it is normal, it's okay. But if it is high risk, if it is showing high risk lesion, then you have to again reconfirm it in the late second trimester. So two-time confirmation is important. And definitely, if the woman has already passed the late second trimester, like she is 32, 34, 36 weeks, then you will do it after delivery 3 months. So these are also common questions, that when you will do the colposcopy, when you will delay the screening, when you will not delay the screening. These are common recall questions. So don't forget it. And this is really important for exam. Now, as I told you, screening, you are not going to delay if involved uncertain margin. You will do it then and there. You will not delay till after delivery. And colposcopy, we are doing to rule out invasion. Now, staging of cervical cancer, very important for us to stage because most of the time the cervical cancer invades locally, affect the vagina, perimetrium, uterosacral ligament. These are the local areas will be first involved. And then will be the distant bladder, rectum, and lymph node. These all will be involved. If lymph node is involved, it is a worse prognosis. That's why if you see in the treatment, they are deciding the treatment modality by lymph node involvement. If it is involved, means it is a severe thing. If it is not involved, means you are happy. And then you can do the conservative management easily in pregnancy. So lymph node is very important in deciding your management. As in pregnancy, we know that CT scan is not safe. So MRI will be the first line of imaging for cervical cancer in pregnancy. So if they give you an SBA, which is the investigation of choice, you will choose MRI, not CT. CT is contraindicated in pregnancy because of the excessive radiation. It could harm the baby. So you will not choose it as first. But if you have high suspicion of lung or pleural spread, then you can do the chest CT, chest X-ray, whatsoever. Chest X-ray anyways is a safe thing. You can always do in pregnancy with abdominal shield. So chest X-ray, no problem, but CT scan, if needed, if high suspicion, you will not delay it because mother health is more important than anything else. Ultrasound you can do to rule out the hydronephrosis because in stage 3 there is hydronephrosis. So you can rule out that, but you have to keep in mind that 90% there could be hydronephrosis due to physiological changes. So that you have to keep in mind. Chest X-ray, if you want to rule out and assess lung metastasis, you have to do chest X-ray. Lymphadenectomy and sentinel lymph node biopsy, they say that you should do lymphadenectomy, but they say that after 22 weeks, the lymphadenectomy is difficult. And because of the gravid uterus, you cannot sample enough. So lymphadenectomy is not recommended after 22 weeks because it's difficult, challenging, less informative. So you're not doing it. So you will do it only less than 22 weeks and that will help you in guiding your further treatment. And sentinel lymph node biopsy, they say that it is not recommended in pregnancy. Still, more studies, more data is needed. So you will not choose sentinel lymph node biopsy and laparoscopic lymphadenectomy only less than 22 weeks you will choose because they say that after 22 weeks it is limited. So don't do it. So this is all about the investigation of for the staging of cervical cancer in pregnancy. Am I clear about this slide? Okay, great. Now, types, if you see the types, 85% most common is squamous cell, and after that, second most common is adenocarcinoma. So what is specific about adenocarcinoma is adenocarcinoma lead to ovarian metastasis. So if you find adenocarcinoma, you should remove the ovary also. And if she's a young woman and if you remove the ovary, you have to discuss with her because she will lose her fertility. So that all aspect, the fertility aspect you have to take care because cervical cancer is usually of reproductive age group women. As we saw now, it is moving towards the late age, but because of vaccination, but still it is a reproductive age group problem. So that's why always we have to keep the fertility in mind. High risk type like small cell and clear cell, you cannot delay the treatment because they are high risk. So you will never do conservative treatment for them. Now staging. If you see the staging very important. Stage 1, 2, 3, and 4. If you see stage 1 strictly confined to the cervix. Stage 2, beyond the uterus, but not going to the lower two-third of vagina or pelvic wall. So it's going to beyond the uterus means upper two-third of vagina is involved, parametrium is involved, but not the pelvic wall or lower one-third. Here now it will be lower one-third and parametrium up till pelvic wall will be involved. Then hydronephrosis, non-functioning kidney and nodes will come. So if you see the nodes, 3C will be in the nodes, out of which one will be pelvic and two will be para-aortic. So these are the stage 3. Then stage 4 will beyond the true pelvis. So it is going beyond the true pelvis, distant metastasis and mucosa, bladder and rectum. So these are the staging. Staging, I cannot emphasize enough that staging you have to memorize because sometimes they will simply ask you staging, which stage it is. Sometimes they will give you the description of stage and ask you the survival rate, ask you the treatment. So staging should be by heart. All the cancer staging you should remember really, really well because mainly they expect you to diagnose the staging. They want you to know the staging and stage wise treatment. They don't want you to know every finer detail, but at least the staging, survival, and the stage wise treatment you should know grossly about all the cancers. Now, if you see stage wise treatment in pregnancy, it will depend upon stage 1A without lymphovascular invasion or 1A with lymphovascular invasion. So if you see 1A without lymphovascular invasion, the risk of nodal involvement in this is less than 1%, which increases to uh, 3 to 6% for 1A2. So that's important. 1A1, the risk of involvement only less than 1%, and 1A2, it becomes 3 to 6%. So if without lymphovascular invasion, you are happy because the prognosis will be good. So simple cone biopsy will be the treatment of choice. Simple cone biopsy between 14 to 20 weeks by knife or laser because you want to examine it histopathologically for the margin. That's why you will use knife or laser, and cone biopsy you will do between 14 and 20 weeks. They can simply ask you in exam, stage 1A without lymphovascular invasion in pregnancy, how to treat. And treatment, they will give you leads, cone biopsy, and different options, hysterectomy or whatsoever. So you will choose the treatment which is suitable for you. use only simple cone biopsy for that women at 14, between 14 and 20 weeks for stage 1A1 without lymphovascular invasion. And you will advise for vaginal delivery because there is no indication of CS here because it's only cone biopsy and it's a simple thing without lymphovascular invasion. So no need of cesarean section in such situation. So they can either ask you how you'll treat you or they will ask you mode of delivery. Both ways it is very important. Then if stage 1A1 with lymphovascular invasion or 1A2 or 1B1, what you will do? In such situation, they say that you can do either simple trachelectomy or you can delay the treatment after delivery or you can do neoadjuvant chemotherapy. So these are the three things recommended for the situation. And you have to offer her LSCS. Regarding the mode of delivery, we will discuss it further, the detail, which incision you will take and how you will treat. So this is also important. Now, 1B1 and 1B2, they say that ideal treatment is radical hysterectomy with bilateral salpingectomy with or without oophorectomy with lymphadenectomy. So you have to remove the uterus, you have to remove both the tube and remove the lymph node and ovary SOS after discussing with the women. So this is also, you should know the basic treatment. So you will apply the different modality according to the gestational age. But what are the recommended treatment for these three conditions in pregnancy? You should know. So these are the recommended treatment stage wise. And if you see more than 22 weeks pregnancy in any stage, you can delay the treatment and you can give neoadjuvant chemotherapy. Because if more than 22 weeks, baby is salvageable. So you want to delay. If less than 22 weeks, you will offer termination. If more than 22 weeks, you will offer them that delay the treatment after delivery. So if you can delay, you will delay. We are talking till B2 only. B2 and then B3. We are not talking beyond that because beyond that it is more severe and beyond that they don't recommend you conservative surgeries. They will recommend immediately chemoradiation or whatsoever. Like they say that surgery and chemoradiation has equal outcome in its advanced stages. So whatsoever. There the mother life become more important. That's why that part they have not covered. Only till B3 they have covered because till that time you can think about conservative surgery and think about the baby. So more than 22 weeks, you can always choose delay the treatment till delivery and neoadjuvant chemotherapy. So simply in any stages, if it is more than 22 weeks, you can always choose delay the treatment. Very important and very simple thing to do correct in the exam. You can easily remember that if the pregnancy is more than 22 weeks, you will delay the treatment and chemotherapy is safe in second trimester. You can easily give chemotherapy to the women. So these are the basic principle you have to remember for the stage-wise treatment in pregnancy. Now, this is the master chart. If you see colposcopy, you have done all the investigation, MRI, ultrasound, you have done the biopsy. If you see here, CT is not mentioned because that is SOS. So MRI, you will be definitely doing colposcopy, clinical examination, MRI, you have done. SOS, you have done ultrasound according to her symptom. If kidney symptoms are there, you have done biopsy and you have done either conization for diagnosis. Now you have staged the pregnancy. What is the cancer stage in the pregnancy? If it is 1A1 without lymphovascular invasion, we already saw, we'll do cone biopsy between 14 to 20. If the margins are positive, you can do re-excision also. You will aim for vaginal birth. As I told you, if it is more than 22 weeks, always you can do the delay treatment and chemotherapy. So it's simple. Anytime if they give you more than 22 weeks, you can easily choose this treatment even up till 1B3. From 1A1 to 1B3, you can delay the treatment, no problem. So this is your treatment modality. Now, if it is less than 22 weeks, as I told you, we can do the lymph node dissection. So we will do the lymph node dissection. We will do the lymph node dissection and see if it is positive or negative. If it is positive means worse prognosis, so you will offer termination of pregnancy. If it is negative means you can offer her simple trachelectomy or delay the treatment, as I told you. They say that this British Cancer Society doesn't recommend even simple trachelectomy for the women in pregnancy because trachelectomy is very challenging procedure as well as it leads to preterm labor, hemorrhage, and all that thing. So they don't recommend it. But yes, in such situation, in early stages, you can do it if needed. So simple trachelectomy or delay the treatment will be your option if lymph node is negative. If positive, termination. If positive, termination. So whenever it is positive, you want to offer her termination, right? So this is how you will plan. If you are giving her NAC, if you are giving her neoadjuvant chemotherapy, means before surgery as we give chemotherapy, so you are giving the chemotherapy, then you can delay the treatment. Means you can delay the treatment after delivery. You will follow in the pregnancy till the 34 to 36 weeks. They say that you will take her and then after that deliver her, and then you will offer her the definitive treatment. So for 1B2, here they have written termination or trichlectomy. In 1B2, they will give you the stages. They will give you the description of stages and they will ask you the treatment. So more than 22 weeks, we are very clear. Less than 22 weeks, we are discussing stage by stage. So 1B2, you have done the lymph node dissection and you saw it as positive. You anytime lymph node dissection positive, you want to offer termination. Just remember this rule. So if it is positive, you want to offer her termination. So how you will offer her termination? She is less than 22 weeks and 1B2. So how you will offer? You can offer her radical hysterectomy and pelvic lymphadenectomy because we saw 1B1 and 1B2. Till that time, you want to do radical hysterectomy. So you will offer her radical hysterectomy and pelvic lymphadenectomy with fetus in situ. They will give you this option in the exam. So you should remember this. How you'll terminate in 1B2. Radical hysterectomy and pelvic lymphadenectomy with fetus in situ. This will be your termination option. And if you are delaying the treatment, if you are delaying the treatment and like here or here, if you are delaying the treatment, then what you will do, delivery will be by cesarean section at appropriate gestation, which is 34 to 36 weeks. And once the baby is delivered, you will do radical hysterectomy with lymph node dissection. So ultimately, your goal in 1B2 is radical hysterectomy with lymph node dissection. If termination, baby in situ. If after cesarean, it will be after cesarean. And here for cesarean, they say that no need of classical cesarean. You can even do lower segment cesarean. So this is a new development. Earlier they told that with CA cervix, you always have to do classical cesarean. Now they have changed that and told that you can do the lower segment cesarean section also if possible. So please keep that in mind because they will give you lower segment, classical, and all the option. And if possible, if it is not a big size, you can choose lower segment cesarean. So you have done this now 1B3. Again, 1B3 because here the chemoradiation, it's mostly the treatment is palliative now. You want to comfort her because you cannot cure her from that. Till here you can cure her, that's why you are doing the radical hysterectomy. Here you cannot cure, so it is more of palliative. That's why you can give her neoadjuvant chemotherapy or you can offer her termination in less than 22. So this will be your treatment. And if it is more than 22, as we already know, we will wait. So what you will do LSCS followed by either surgery or chemoradiation. Because as I told you here, surgery or chemoradiation both has equal outcome. So she can choose whatever she like. So these are all about the treatment. These aspects, please remember that up till 1B2, you are going to do radical hysterectomy and pelvic lymph node dissection. This is very, very important for you to understand. And whenever you are doing the NACT, you will delay the treatment. You will deliver at 34 to 36 weeks by cesarean. By cesarean. It could be lower segment, it could be classical according to the size. A big size, classical, otherwise lower segment. So these all things you should remember really, really well because they will give you similarly in options and you have to choose one. And cone biopsy definitely always their favorite question. So one without lymphovascular invasion, you will choose cone biopsy with vaginal delivery. Am I clear about this master chart? This is the most important slide of today's presentation. So if you have any doubt, you can ask me. Okay, great. Thank you, my dear. Okay, so a word about trichelectomy because earlier we were having 2016 talk of trichelectomy. So here they have mentioned about trichelectomy and cervical cerclage, but they say that the British Cancer Society doesn't recommend it. But if needed, yes, you can go for it. So simple trichelectomy means you only remove the cervix. Radical means you remove cervix. Sometimes they ask you what is radical trichelectomy. So radical means you will remove cervix, parametrium, and upper vagina. So very important for this to understand what is the difference between simple and radical. Here the parametrium and upper vagina will be involved. And always, definitely, the gynec oncologist, whenever they do a trachelectomy, they will do the cervical cerclage, because if you have removed the cervix, how the women will carry the pregnancy. So cerclage is always routinely performed with trachelectomy. The problem with trachelectomy is the risk of preterm delivery, and even earlier they have asked how much is the risk of preterm delivery. So 20 to 30% is the risk of preterm delivery. That's why you don't prefer it as far as possible. So this is also important to remember. Now, how you will monitor them? If they have undergone trachelectomy, you have to do serial ultrasound scan because you want to rule out any shortening, funneling if any preterm is setting in. So serial ultrasound scan you will do fortnightly, means every 2 weeks. Urine genital screening you will do because there are chances of infection, and prophylactic antibiotic you can consider from 16 weeks. And you can consider steroid at 24 weeks because there could be preterm delivery, so why not give the steroid? So these are all things, these are all recommended with trachelectomy, so don't forget this. Delivery, if with trachelectomy, this is also a recall question, that with trachelectomy, what time you will deliver. So you want to deliver a planned pre-labor cesarean. So in earlier talk, they have given 37 weeks. So planned pre-labor cesarean section is what they have mentioned in this new talk. They have not mentioned the gestational age. So just remember it like that, that planned pre-labor cesarean section you want to do because you want to avoid the uterine rupture and massive hemorrhage. And you don't want to damage her trachelectomy also, all in all. So you don't want her to deliver vaginally. You don't want her even to initiate the labor. So you will do it pre-labor cesarean for a trachelectomy women. This is important. So preterm delivery and pre-labor CS, these all two important aspects you have to understand with trachelectomy. Now, chemotherapy, they have talked too much about chemotherapy, so definitely they can give you SBA from chemotherapy, that how you will do chemotherapy in cervical cancer in pregnancy. So you will do chemotherapy, as we all know, in first trimester it is contraindicated. So you cannot give her chemotherapy in first trimester because there are 10 to 20% risk of malformation. So you will not give in first trimester, only in second trimester, contraindicated in first trimester. How you'll calculate? They say that you will calculate as per her actual weight, not pregnancy increased weight. So actual weight, same doses as non-pregnant you can give, and you will give after 14 weeks, after first trimester. When you are giving it throughout the pregnancy, you will not give it beyond 35 weeks because they say that at least 3 weeks window should be there when she is delivering. So beyond 35 weeks, you will not give the chemotherapy session. Regarding the chemotherapy, what drug you will give? So they say that carboplatin and paclitaxel regime is favored over cisplatin because of the nephrotoxicity and ototoxicity due to cisplatin. So they say carboplatin and paclitaxel will be the preferred regime. Sometimes they will give you carboplatin, paclitaxel and different drugs, or cisplatin, paclitaxel. So you have to always choose carboplatin and paclitaxel to avoid the toxicity. It will be weekly or 3 weekly regime. And as I told you, after 35 weeks, you will not give because you want a 3 week gap between delivery and the chemotherapy because bone marrow will be depressed. So you don't want her to deliver in an immunocompromised state. So this is your precaution for that. Now, timing and mode of delivery, I already told you earlier that if you are giving her NACT, you can deliver her by 34 to 36 weeks to avoid the complication of prematurity. They can simply ask you in SBA that what time you'll deliver her. They can ask you what incision you will take. So traditionally it was vertical midline upper segment incision, but now they are saying that lower segment, if sufficiently developed, you can do it. Lower segment transverse incision can be done. Lower segment cesarean section can be done if possible, if lower segment is sufficiently developed. If tumor itself is very large, you don't want to trouble the tumor because tumor will bleed too much. And they say that if the women deliver vaginally and there is cervical tumor, the chance of tumor recurrence in episiotomy wound is more compared to the abdominal wound. So chance of recurrence is more, bleeding is more, it can lead to obstruction and difficult delivery. So all this trouble, why to take? Why not do the cesarean? So if tumor itself is very high, large, you will choose the classical cesarean section to reduce the blood loss because definitely if tumor in the cervix it will bleed too much, so you don't want to go in that area, so you will do the classical cesarean section for that women. So this is very important, timing and mode of delivery, and even very interesting also because it is the new change. And we have seen the stage wise treatment, which is very, very important. And always they give you a stage or description of stage and ask you how you will treat her. So this is all about this talk, and I'm very happy that we could share this talk today. Regarding the breastfeeding, you have to remember that you cannot breastfeed if she's on chemotherapy. But if she's taking chemotherapy, she can stop it for 2 weeks and then she can give the breastfeed. It's the same like breast cancer. You must have read in the GTG of breast cancer that if she is taking chemotherapy, she has to stop it at least for 2 weeks before starting the breastfeed. So that is the aspect of breastfeeding. So this is all about the stock. Now a word about whatever the course is running. So now the crash course you can join at 99. These are the features. This is the September course starting in May. Early bird discount of 299. This is the course features. This is the Jan course. Registration already started. It is having a free crash course. This is a 7-month course, which last time when we started, the students are really very happy about. So this course registration already started. If you have planned for Jan, you can start your preparation from now, because earlier the better. You can revise more times and you will become more confident before exam. This is our group link, Facebook and Telegram link. We have already started the recall discussion for the July exam. So, and also we can solve any doubt if you have regarding the exam, regarding the TOG reading, even TOG recordings are there. So all in all, it helps you in complete preparation. If you are, it helps you in your troubleshooting. So if you want, you can join this group of Telegram and Facebook for further assistance. And link are there in the description also. If you like the video, you can subscribe, like, share it with your friends so everybody can get benefited, and press the notification bell so that you will get notification if a new video is posted. So thank you very much for attending today, and I wish you all the best for your exam.